There is this really persistent myth out there, especially when you are first stepping onto a pediatric clinical floor for the very first time.
Oh, the tiny adult theory.
Exactly. The tiny adult theory. It's this assumption that pediatric nursing is basically just, well, adult nursing in miniature.
Right, like you can just take the standard adult rule book, shrink the medication dosages down by weight, grab a smaller blood pressure cuff, and, you're fully equipped to care for a toddler.
Which is so wrong.
It is remarkably dangerous, clinically speaking, because operating under that assumption ignores the fact that children are physiologically entirely distinct organisms.
Which is exactly why we are here. Welcome to the Deep Dive. Today we are serving as your ultimate study companion for the ATI RN Pediatric Nursing Proctored exam.
We are going to prove exactly why kids are not just tiny adults.
Yeah, we're looking at their entirely unique immune defenses, right? From the highly specific ways their bodies react to vaccines to the anatomical quirks that make them absolute magnets for ear infections.
And we are pulling all of our insights directly from the ATI RN Nursing Care of Children Review module, specifically chapters 35 through 38.
Right, but our mission today isn't just to read the book to you. We're stripping away the dense medical jargon and really focusing on the underlying mechanisms.
Because the goal is to give you the clinical why behind the facts. If you understand the actual mechanics of a pediatric disease, you do not have to rely on rote memorization for the exam.
No, you'll just inherently know the correct nursing intervention.
Exactly.
So let's start by looking at how we artificially armor a child's immune system. Immunizations. Chapter 35.
Because before we get into treating sick kids, we really have to look at how we prevent them from getting sick in the first place.
Right. But administering vaccines to a pediatric population comes with a very specific set of rules, and it starts with the physical act of giving the injection itself. ATI heavily emphasizes this concept of atraumatic care.
Which basically means we are actively working to minimize physical and psychological distress. For infants, the absolute standard site for an intramuscular injection is the vastus lateralis muscle, so that thick muscle on the outer thigh.
But the atraumatic component isn't just about picking the right muscle. It involves a very specific protocol utilizing sucrose.
Yes, the sucrose guideline. The protocol dictates that you give the infant a concentrated oral sucrose solution, which is usually just dipped on a pacifier.
And this is something I always assumed was just, a distraction technique, like handing them something sweet so they look away.
A lot of people think that. But no, there is a highly testable timeline attached to this for a physiological reason.
Right. You administer the sucrose 2 minutes prior to the injection. You keep it there during the injection, and you continue it for 3 minutes after.
The timing is crucial. It takes about 2 minutes for the sucrose and the physical act of non-nutritive sucking to actually trigger the release of endogenous opioids in the infant's brain.
Wait, really? The body's natural painkillers?
Exactly. So if you just dip the pacifier and immediately give the shot, you haven't given the nervous system time to mount that analgesic response.
Oh, wow. That is a perfect example of understanding the mechanism behind the protocol.
Yeah.
It's not just sugar. It's literal pain management.
It really is.
Okay, so once that vastus lateralis injection is done, the paperwork begins. And the documentation requirements are super rigorous.
They have to be.
You have to chart the publication date of the vaccine information sheet, the VIS, that you handed to the parents, plus the vaccine's manufacturer, the expiration date, your specific title as the administering nurse, and the lot number.
I always tell students the lot number is your traceability lifeline.
How so?
Well, vaccines are manufactured in massive batches, right? If, say, months down the line, a specific batch is found to have a contamination issue, or it's linked to an unusual cluster of adverse reactions.
They need to find everyone who got it.
Exactly. The CDC and the FDA rely on those charted lot numbers to track down every single child who received a vial from that specific batch.
So it is purely a massive public health safety net.
Right.
Speaking of safety, let's look at when we absolutely do not armor the immune system, the contraindications.
Oh, the exam loves to test absolute rules.
Yes, they do. And there is a major one regarding the hepatitis B vaccine.
There is. If a child has a severe anaphylactic allergy to Baker's yeast, the hepatitis B vaccine is strictly contraindicated.
Baker's yeast.
Oh.
Like for bread.
Yeah, exactly. The vaccine is actually manufactured using recombinant DNA technology inside yeast cells. So yeast allergy equals no Hep B.
That is such a specific, testable fact.
Oh.
Okay, then we have the live attenuated vaccines, the heavy hitters like MMR, so measles, mumps, and rubella and varicella, which is chickenpox.
Right, and these are contraindicated for any child who is immunocompromised.
It's a live virus, right?
Exactly. A live attenuated vaccine contains a weakened but still living version of the actual virus. A healthy pediatric immune system easily recognizes that weakened virus, fights it off, and builds a memory of it.
But if they are compromised,
Right. If a child's immune system is compromised, say they are undergoing chemotherapy, they don't have the cellular soldiers to fight off even that weakened virus. The vaccine itself could cause a severe system-wide infection.
which leads right into post-vaccine care. So a child with a healthy immune system gets a live vaccine, they go home, and their body starts working to build those antibodies.
And often, that work presents as a low-grade fever.
Right. But there is a massive safety warning here. You never, ever instruct a parent to give aspirin to a child for a viral fever or a post-vaccine fever.
Never. The administration of aspirin or really any salicylate to a child recovering from a viral illness or a live virus vaccine is directly linked to Reye syndrome.
Reye syndrome, that's the one that causes acute encephalopathy, right?
Yes, massive swelling in the brain alongside severe fatty infiltration and damage to the liver. It's life-threatening.
Brain swelling and liver failure, literally just from treating a fever with the wrong over-the-counter bottle.
Which is why you always instruct the caregivers to use acetaminophen instead.
Always acetaminophen. Okay, now I want to look at the CDC immunization schedule itself, because to a nursing student, it looks incredibly intimidating. It's like a complex subway map.
It really is, yeah.
But let's clarify how the schedule actually operates in the real world. Here's a common student pushback. Wait, if a kid completely misses their 4-month checkup and they don't come back until they're 8 months old, do we have to start the entire vaccine series over from day one?
Almost never. I actually like to think of the CDC schedule like a train route.
Okay, a train route.
Yeah, if a passenger misses their connection at the 4-month station, you don't send them all the way back to the start of the line. You just put them on the next available train from the station they're currently at.
Oh, I see.
The CDC has a highly specific catch-up schedule. You rarely restart the series. You just pick up where the child left off, as long as you adhere to the minimum required waiting time on the platform between doses.
Catch the next train. Just observe the minimum wait time on the platform. That makes it so much less daunting.
It really does.
Okay, so we've established how to artificially armor the immune system. But what happens when that armor isn't there? Say a child misses their train completely, or the surrounding community loses herd immunity.
Well, that leaves children vulnerable to highly communicable diseases. Chapter 36.
Right. And when one of these diseases enters a pediatric unit, a nurse's immediate priority shifts to containment.
Because containment means mastering isolation precautions. If you do not know how a disease travels, you cannot stop it from spreading to other vulnerable patients.
I find the easiest way to lock this in is to visualize the clinical environment. So airborne precautions are essentially treating the pathogen like a toxic gas leak.
A gas leak, exactly.
The infectious particles are so microscopic that they can remain suspended in the air for hours, just floating out into the hallway and into the hospital's ventilation system.
Right, which is why you need special negative pressure rooms that constantly pull the air inward, and anyone entering needs a fitted N95 respirator.
But droplet precautions, on the other hand, are like someone sneezing with a squirt gun.
Ha! That is a very accurate, if slightly graphic, way to picture it.
But it works.
It does. The infectious droplets are large and heavy. They are propelled through the air when the child coughs or sneezes, but gravity pulls them to the floor very quickly, usually within about 3 feet. They don't float into the vents.
So for the squirt gun scenario, you just need a standard private room, and you wear a standard surgical mask when you step inside that direct 3-foot splash zone.
Exactly.
So applying this to the ATI testable diseases, airborne, the gas leak is required for varicella, which is chickenpox, and measles, specifically rubeola.
Correct. Both of those require airborne precautions, so negative pressure isolation. And then for droplet precautions, the squirt gun you're looking at, pertussis, mumps, rubella, and fifth disease.
Let's actually paint a clinical picture of these diseases because the exam frequently gives you a patient presentation and expects you to identify the pathogen. Let's start with pertussis, which most people know as whooping cough.
So pertussis is incredibly deceptive because it usually begins with symptoms that are completely indistinguishable from a mild common cold.
Just a runny nose, basically.
Right. But then it progresses into paroxysmal coughing fits. The child enters a coughing spasm so rapid and continuous that they literally cannot expel enough air or take a breath in.
That sounds terrifying.
It is. And when the spasm finally breaks, the child takes a massive, desperate gasp for air through a narrowed airway, which creates that characteristic loud, high-pitched whooping sound.
And the physical toll of that is immense,
Yeah.
right? The coughing is so violent that teenagers and adults can actually suffer rib fractures.
Rib fractures, yes. Or they can experience syncope fainting just from the sheer lack of oxygen during the spasm.
Wow. Okay, moving down the droplet list, what about fifth disease?
Fifth disease has a very distinct visual hallmark. The child will present with an intense erythema on their face that looks exactly as if they've been slapped across the cheeks.
Just bright red, slapped cheeks.
Exactly. And interestingly, as it progresses, it can cause severe arthralgia or joint pain, which is a symptom you actually see much more frequently if an adult caregiver catches it from the child.
Okay, so slapped cheek equals fifth disease. Got it. What about mumps?
Mumps specifically targets the salivary glands, predominantly the parotid glands located in the cheeks and jaw area.
Yes.
So a child will present with very painful, visibly swollen cheeks.
Right.
But clinically, we're deeply concerned about where the virus travels next. In males, it can cause orchitis, which is severe inflammation of the testicles, and it's also a leading cause of viral deafness.
Oh, wow, deafness. Okay, now let's jump back to the airborne list.
Varicella.
Chickenpox. I mean, everyone has a mental image of a kid covered in calamine lotion, but how do we describe it clinically on an exam?
Well, the terminology is very specific. Mecule, papule, vesicle, crust.
Break that progression down for us.
So it's a dynamic rash, meaning it actively changes form. It begins as a mecule, which is just a flat red spot on the skin, usually starting on the trunk.
Okay, flat spot.
Then that flat spot raises up into a solid bump, which is the papule.
Right.
That bump then fills with clear fluid, becoming a vesicle, so a blister. And finally, the vesicle ruptures and dries into a crust or a scab.
Macule, papule, vesicle crust.
Right, exactly. And what is highly characteristic of varicella is that you will look at a child's back and see all four of those stages present simultaneously.
That is super helpful for visualizing it. Now, I want to look at rubella, also known as German measles. It requires droplet precautions.
Yeah.
But clinically, the symptoms in a child are remarkably mild. Right.
Very mild. Maybe a low-grade fever, a sore throat, a faint rash.
Right. So if it is so mild, why is it considered a major public health threat? Why do we vaccinate so aggressively against it?
Because the primary threat of rubella is not to the child who catches it. The threat is to the unborn.
Oh, I see.
If a pregnant woman without immunity is exposed to a child shedding the rubella virus, especially during her first trimester, the virus crosses the placenta, and it severely disrupts the development of the fetus, leading to congenital rubella syndrome.
So we are talking about permanent, devastating birth defects.
Yes. Deafness, severe cardiac anomalies, liver damage. The aggressive vaccination of children against rubella is perhaps the purest example of herd immunity we have.
Wow. We armor the children to build a protective wall around pregnant women and their developing babies.
Exactly.
Okay, so we've looked at these communicable respiratory bugs, but very often, these exact same respiratory pathogens migrate to a very specific, anatomically vulnerable location in children.
The middle ear, chapter 37.
Yes, causing acute otitis media, or AOM. And this brings us right back to our opening premise. A child's ear infection isn't just a random occurrence. It is entirely dictated by pediatric anatomy.
It really is a structural issue. To understand AOM, you have to look at the eustachian tube, which is the canal that connects the middle ear to the back of the throat.
Right. Its job is to drain fluid and equalize pressure.
Yes. And in a mature adult, that tube is angled downward. Gravity naturally pulls fluid down and out into the throat.
Like a properly installed plumbing pipe.
Exactly. But in an infant or a toddler, that pipe is shorter, and it lies almost completely horizontal.
So gravity isn't helping at all.
Not at all. Because it is horizontal, when a child gets a mild respiratory infection, the surrounding tissue becomes inflamed and easily pinches that narrow tube shut.
And the fluid gets trapped.
Yes, fluid from the illness gets trapped behind the eardrum in the middle ear. That fluid is warm, dark, and stagnant, which is the absolute perfect breeding ground for bacteria like Streptococcus pneumonia.
So the anatomy traps the fluid, and the bacteria throw a party.
Pretty much.
And that structural quirk is why the incidence of AOM peaks heavily in children under 24 months, and then it actually spikes again around ages 5 to 6 when they enter school and encounter a whole new wave of respiratory bugs.
Right.
Now, the clinical guidelines also flag secondhand smoke as a major risk factor for AOM. How does smoke specifically worsen this anatomical problem?
Well, the respiratory tract and the eustachian tubes are lined with cilia, these microscopic hair-like structures that act like tiny brooms, constantly sweeping fluid and debris away.
Right.
Secondhand smoke actually paralyzes those cilia. If the brooms stop sweeping, the fluid stagnates even faster in that horizontal tube, dramatically increasing the risk of infection.
So smoke essentially shuts down the active drainage system.
Completely.
What about protective factors? How do we help that horizontal pipe stay clear?
Breastfeeding is a highly tested protective factor against AOM, and it works on two fronts.
Okay.
Immunologically, breast milk is rich in IgA antibodies, which provide direct protection against the specific respiratory pathogens that cause AOM. But mechanistically, it comes down to the feeding position.
Right, because when an infant breastfeeds, the caregiver naturally holds them in a semi-vertical position.
Yes. But bottle-fed infants are frequently laid flat on their backs during a feeding. If you feed an infant flat, that liquid can easily reflux right up into that horizontal eustachian tube pooling in the middle ear.
That makes total sense. It's immune protection combined with the mechanical advantage of gravity. Now, clinically assessing AOM in a preverbal child requires looking for behavioral cues, right? Because a 12-month-old cannot just point to their ear and describe the pain.
No, they can't. You will see them tugging or pulling at the earlobe. But the most telling sign is intense crying, specifically when they are laid supine or flat on their back.
Because lying flat shifts that heavy infected fluid, increasing the pressure directly against the tympanic membrane, the eardrum.
Yes. And when the healthcare provider looks inside with an otoscope, they will see a tympanic membrane that is bright red and physically bulging outward from the pressure.
Yikes.
And furthermore, if they apply a tiny puff of air into the canal, the eardrum will not move at all because the space behind it is completely packed with fluid.
Now, I have to look at the treatment guidelines here, because as a nurse, your instinct is to immediately relieve pain. If an ear infection is this painful, and the eardrum is bulging, why is the standard of care not just an immediate prescription for antibiotics like amoxicillin for every single child?
This is where pediatric nursing requires immense clinical judgment and a really deep understanding of antibiotic stewardship. ATI is very specific here.
Okay, let's unpack that.
If a child is over 6 months old and presents with severe manifestations, meaning a high fever over 102.2, or severe pain lasting more than 48 hours, yes, you administer antibiotics.
But there's a massive caveat for milder cases,
A
right?
huge caveat. If you have a child between 6 and 23 months old with bilateral AOM, but they do not have those severe manifestations, the preferred guideline is a period of observation or watchful waiting for 48 to 72 hours.
Wait, so you just manage the pain with acetaminophen or ibuprofen and wait. I imagine that is a really tough conversation to have with a stressed parent. Why take that route?
Because a significant percentage of these ear infections are actually viral, meaning antibiotics will do absolutely nothing.
Right.
Or they will just resolve spontaneously as the inflammation naturally decreases and the tube finally drains. By waiting, we prevent the unnecessary administration of antibiotics, which directly prevents the creation of highly resistant bacterial superbugs.
Okay, that makes sense. Now, if a child suffers from chronic, repeated AOM, the anatomical fix is a myringotomy, right?
Yes.
Where a surgeon places tiny temporary tubes directly through the eardrum to force the trapped fluid to drain outward into the ear canal, just bypassing that blocked eustachian tube entirely.
Correct. It is a mechanical solution to a mechanical problem.
And AOM perfectly demonstrates how localized anatomy creates vulnerability. But moving to our final topic, Chapter 38, I want to examine what happens when the vulnerability isn't localized to a single horizontal pipe, but involves the total systemic collapse of the child's immune defenses from birth.
We are talking about pediatric HIV and AIDS.
Yes.
Clinically, HIV, the human immunodeficiency virus, operates by targeting and destroying a very specific subset of white blood cells known as CD4 T lymphocytes.
CD4 cells.
You can think of CD4 cells as the generals of the immune system's army. They identify threats and coordinate the body's entire response.
And as the virus destroys those generals, the immune army falls into chaos. They can no longer recognize or fight off opportunistic infections that a normal immune system would instantly crush.
Exactly. In pediatrics, the primary routes of transmission are perinatal, meaning the virus crosses from an infected mother to the baby in utero or during the trauma of delivery, or it is transmitted postpartum through infected breast milk.
Which brings us to a highly complex, highly testable clinical scenario: diagnosing the infant. If infant under 18 months of age is born to an HIV-positive mother, you cannot use the standard ELISA screening test to diagnose them.
No, you absolutely cannot. You must use a polymerase chain reaction or PCR test alongside a virus culture.
Let's logically break down the mechanism there. Why is the standard ELISA test useless for a baby under 18 months?
Because of how the tests function. The ELISA test does not actually look for the HIV virus itself. It looks for the specific antibodies the immune system creates to fight the virus.
Okay, so it's looking for the wanted posters, not the actual criminal.
I love that, yes. But during pregnancy, maternal antibodies freely cross the placenta to provide passive immunity to the fetus.
Oh, I see.
So an infant born to an HIV-positive mother will have the mother's HIV antibodies circulating in their bloodstream for up to 18 months after birth.
Wow.
If you run an ELISA on a 6-month-old, it will come back positive because it detects the mother's antibodies, falsely labeling a potentially healthy infant as HIV positive.
That is fascinating. So the PCR test is required because it bypasses the antibodies entirely and looks for the actual DNA or RNA footprint of the virus itself within the infant's blood.
Exactly.
Now, if an infant is definitively diagnosed via PCR, ATI categorizes the clinical progression of the disease into 4 stages: N, A, B, and C. And this progression directly correlates with the gradual depletion of those CD4 generals, right?
Right. So you start with category N, which literally just stands for not symptomatic. The virus is actively replicating, but the immune system hasn't collapsed yet. Then you slide into category D, which represents mildly symptomatic disease. The immune system is starting to slip. You might see hepatomegaly, so an enlarged liver, as the body tries to filter the infection, or oral candidiasis, which is thrush.
And thrush is just a simple fungal infection in the mouth that a healthy immune system easily suppresses, right?
Yes, but here it takes hold. Then category B is moderately symptomatic. The CD4 count is dropping lower. The clinical picture gets darker. You see persistent anemia, recurring bacterial meningitis, or cardiomyopathy affecting the heart muscle.
And then category C.
Category C is severely symptomatic. This is the clinical definition of AIDS.
Wow.
The immune generals are almost entirely depleted. The gates are completely unguarded. This is when severe opportunistic illnesses invade. You see Kaposi's sarcoma, severe wasting syndrome where the body basically consumes itself, or pneumocystis carinii pneumonia, which is a rare, aggressive pneumonia that preys almost exclusively on shattered immune systems.
To prevent a child from sliding down those categories, nursing care relies on antiretroviral therapy, or RT. But you never administer just one drug. It is always a complex combination.
Right, because the HIV virus mutates at an astonishing rate. If you attack it with a single drug, the virus quickly mutates a defense against it and becomes resistant.
So we use combination therapy.
We combine nucleoside reverse transcriptase inhibitors with protease inhibitors.
Essentially attacking the virus at multiple different stages of its replication cycle simultaneously, so it cannot adapt fast enough to survive.
Exactly.
Now let's connect the dots back to the newborn nursery. If an infant is born to an HIV-positive mother, and we know we cannot definitively diagnose them for months due to the maternal antibodies, do we just leave them exposed and wait?
Absolutely not. The standard of care mandates that infants born to infected mothers are immediately placed on prophylactic antibiotics, specifically trimethoprim sulfamethoxazole, commonly known as Bactrim.
And this isn't to treat HIV, right?
No, it is to shield the infant from that deadly pneumocystis pneumonia while we wait. They remain on that prophylactic shield until repeated PCR testing definitively rules out the HIV infection.
You shield them until you know for sure. And if they are positive, nursing care shifts to managing the systemic toll. You mentioned wasting syndrome in category C. The metabolic demand on a tiny body trying to fight a chronic systemic infection is astronomical.
It is. They burn calories at a massive rate, leading to failure to thrive.
Which means aggressive nutritional support is a paramount nursing intervention.
These children require highly specific, high-calorie, high-protein diets. And if their gastrointestinal tract is too compromised to absorb nutrients, we must advocate for total parenteral nutrition. So feeding them intravenously just to give their bodies the fuel required to survive that metabolic war.
So bringing this entire deep dive together, We have established that pediatric nursing operates on a completely distinct physiological axis,
Not tiny adults.
not tiny adults. We navigated the precise rules of artificially armoring the immune system with vaccines, down to the physiological timing of a sucrose pacifier. We visualize the clinical reality of communicable diseases, understanding how a viral gas leak differs from a droplet squirt gun.
Yeah, we looked at the architectural flaws of the pediatric eustachian tube.
And we mapped out the systemic collapse of pediatric HIV, understanding exactly why we rely on PCR testing to find the true footprint of the virus.
So you are no longer just memorizing isolation protocols or medication schedules. You now understand the underlying mechanical and immunological reasons why these ATI guidelines exist in the first place.
Before we wrap up, I want to leave you with one final thought to mull over as you organize your study notes. We are currently living through an era of exponential scientific acceleration. mRNA vaccine technology is rewriting the rulebook on how we train the immune system, and modern antiretroviral therapies can suppress HIV viral loads to completely undetectable levels.
It's amazing.
With these massive leaps, will the pediatric nursing field eventually shift from actively managing these infectious disorders to completely eradicating them? Will the nursing students of the next generation even need to study the progression of varicella lesions or the sounds of a pertussis whoop, or will these chapters be relegated entirely to medical history?
That is a great question.
It is an incredible time to enter the medical field. But until that day comes, remember the golden rule. Kids are not tiny adults. You now have the pediatric playbook. Good luck on your exam.